The next session is Hereditary Breast and Ovarian Cancers Risk Management Recommendations. The presenter is Tua Powell, is an associate member of the Department of Internal Medicine and Department of Cancer Epidemiology at the Moffitt Cancer Center. Dr. Powell's research interests include epidemiologically based studies focused on inherited cancer predisposition. Her research has spanned the cancer prevention and control continuums with evaluations of genetic etiology, cancer risks, and outcomes, including efforts to investigate the etiology of breast cancer in high-risk Black women. I'd like to welcome to the stage Dr. Powell for the last session of the conference here. So we saved the best for last, hopefully. Welcome, Dr. Powell.
Okay, so thank you. I wanted to thank the organizers for inviting me to present on this topic. I'm a clinical geneticist based at the Moffitt Cancer Center. So to go through the objectives of this talk, we're going to identify genes associated with hereditary breast and ovarian cancer, including newer emerging genes. We're going to go through and summarize risk management recommendations for hereditary breast and ovarian cancer, and then be familiar with genetic testing strategies and limitations of interpreting a negative test result. So going through genetic testing in individuals, ASCO has had some long-standing guidelines about testing. So it really should be performed in individuals with a personal or family history suggestive of an inherited cancer susceptibility. It needs to be performed in a setting where the results can be adequately interpreted. And then the test results need to make a difference, either in terms of personal health or in terms of health for family members. So when we're thinking about hereditary breast and ovarian cancer, most cancer is sporadic. So it's only a smaller proportion that are hereditary, and that differs by cancer type. So for breast cancer, it's about 7 to 10% that we consider hereditary. For ovarian cancer, that's a little more. But when we're looking at the hereditary proportion, both for breast and ovarian cancers, BRCA1 and BRCA2 account for the majority. But there are other genes. So that includes both for breast cancer, we have the TP53 gene that predisposes to Li-Fraumeni syndrome, P10 gene, which is associated with Cowden syndrome, as well as others. And then for ovarian cancer, we know about the Lynch genes, and I'm going to talk about some other emerging newer genes. So when we are generating a differential diagnosis, it's really informed by a comprehensive family history. So what we have are various different cancers that we're looking at, as well as other findings that could be suggestive of inherited risk. So if we think about breast and ovarian cancer, our main genes that we would be concerned about would be BRCA1 and BRCA2. In contrast, say we have a constellation of macrocephaly, meaning large head, breast cancer, renal cancer, thyroid cancer, some colon polyps, as well as some skin findings called tricholamomas. What condition would we think of? I think this is an audience response system. So it looks like the majority got it right. It's Cowden syndrome. Going through another scenario where we have breast cancer, sarcoma, leukemia, and brain cancers. What conditions would we think about? Okay, so again, that is totally correct. And then another scenario where we have breast cancer and pancreatic cancer, what conditions would we think of? That's perfect. So actually going back to, do I have the slides again? Okay. So going back to the last question, again, the BRCA1 and 2 are the ones we think about with that situation with breast cancer and pancreatic cancer, but there are some newer emerging genes that we also need to be thinking about, which I will go through later on in the talk. So here's another question. When to consider testing? So you perform BRCA testing on an unaffected 33-year-old woman with 2 sisters diagnosed with breast cancer below the age of 50 and a paternal grandmother with ovarian cancer. Her breast cancer results return as no mutation detected. So how do you advise the family? Number 1, she is at a general population risk for breast and ovarian cancer. Number 2, there is no BRCA mutation in the family. Number 3, testing her sisters with breast cancer would help to interpret her negative test result. Number 4, testing her unaffected brother would help to interpret her negative test result. And then number 5, options 1 and 2 above. I think there should be an audience response system here again. Excellent. So I wanted to focus on this concept a bit more. So when we are talking about interpretation of genetic test results, the way I think of each gene is like a big set of encyclopedias. So when we're doing the testing, we're basically reading through the entire set of encyclopedias, looking for a spelling mistake. So there are 3 possible test results that we can get. We can get a no mutation detected, or a normal or a negative result, where we read through the entire set of encyclopedias and everything looks normal. A clearly positive result, where we find a clear-cut spelling mistake that leads to something in that gene not working properly and leading to an elevated cancer risk. And then the third type of result, which is what we call a variant of uncertain significance, which happens about 5% of the time every time we test for 1 or 2 genes. So it's a pretty common result to get. But what's important to remember here is we all have variation in our genetic code. So variation in and of itself is normal. So when we get a variant result, that doesn't necessarily mean that there's something wrong with the gene. All it means is there was something that's a little different from normal. When these results are reclassified, most of the time they're reclassified as normal. So again, very important to remember that. We don't act medically on variant results. So going back to our no mutation detected results, important to remember we have our true negatives versus we have our uninformatives. And what I mean by that, let's go through the uninformatives a little more. So this ties into the concept of best testable. So let's say we have this family history or family tree where we have Kelly, who doesn't have a cancer diagnosis. She's age 33. She's got a 2 sisters with breast cancer diagnosed at age 35 and 39, and a grandmother with ovarian cancer. Say we start testing Kelly first, and she's negative. Well, that doesn't tell us very much, because her being negative could mean that, yes, she's truly a negative and her sister would have been positive, which is reassuring, versus if we wouldn't be able to find the genetic etiology of the inherited cancer in the family, then her negative result doesn't mean as much. When we reverse the scenario, say we start with testing Sue, her sister first, who has a prior diagnosis of breast cancer. Well, if we find a mutation in her, presumably that has tracked through the family, and Kelly doesn't have it, then we can put her back to general population risk. So that is a very important distinction. Whenever we start with someone that's unaffected, we don't get the best interpretation in the family. That doesn't mean that we don't test the unaffecteds if they're the only ones that we are able to test, but there are limitations in interpretation of the test results in that scenario. So let's start with a patient scenario, a story of Anna and Irene. So we have here the family history 11 years ago. So Irene, at the age of 49, was diagnosed with breast cancer, treated with a lumpectomy. And she had a family history of a paternal aunt who had died of ovarian cancer in her 60s. She's got 2 daughters, ages 24 and 19. Now let's fast forward 11 years later, the current family history. So Irene is 60, had a breast cancer diagnosis at age 49. She has the paternal aunt with the ovarian cancer. Her daughter, Anna, who is now age 35, has 4-year-old twin daughters. Her sister, or her cousin, Irene, was diagnosed with ovarian cancer a couple of years ago. And Anna has just been diagnosed with stage 4 breast cancer. She is subsequently tested for a inherited breast cancer, has a BRCA1 mutation, not surprisingly. Her mother also has a BRCA1 mutation, and you can see how it tracks through the family. Again, very important to remember, there is another at-risk family member here, Olivia, age 30, who we don't know whether they have the mutation or not, but could very much benefit from knowing this information. So when we're thinking about BRCA mutations, really what we have to remember is there are much higher risks of both breast cancer and ovarian cancer that increase over time. So by age 40, we're talking about a 20% 20% risk of breast cancer, which goes up to around 60 to 70% by age 70. The ovarian cancer risk is about up to 44% for BRCA1 by age 70. For BRCA2, it's a little lower. It's about up to 27%. Now, the other thing here is we do have this risk for second breast cancers in individuals with a BRCA mutation, and it's much higher if you have a BRCA mutation compared to if you don't. So looking into that a little bit more, there was a study that was published in JCO a little earlier this year. It was a Dutch study of over 6,000 women with breast cancer diagnosed below the age of 50. And that included 200 BRCA1 mutation carriers as well as 71 BRCA2 mutation carriers. And what they found was the 10-year cumulative breast cancer risk in BRCA1 carriers was 21.1%. BRCA2 was 10.8%, in non-carriers was 5.1%. So it really does make a difference in terms of second breast cancer risk when you have a BRCA mutation. Now, what was also very important in this study was that when they looked at non-carriers and looked at the women that were below age 40 versus above age 40, the risk of second breast cancer didn't really change. You can see that the curves really overlap completely. In the carriers, very, very different situation, where those who were below age 40 at the time of their initial breast cancer diagnosis had a much higher risk of second breast cancer compared to those that were above age 40. So again, summarizing this data, in the non-carriers, the risk of a second breast cancer was 5.1%. In BRCA1, if they were below age 40, it was 25.5%. And if they were above age 40, it was 15.6%. And we saw the same trends, or they saw the same trends in BRCA2, but the effect was a little bit less. So, big picture-wise, both BRCA1 and BRCA2 increase the risk of a second breast cancer. The risks are lower with BRCA2 compared to BRCA1. So this is another way to tailor the risks to individual patients with BRCA mutations. Now, when we're looking at the NCCN guidelines, we do have specific medical management guidelines in there about how to manage individuals with a BRCA mutation. And again, we do recommend the breast MRI start at age 25 on a yearly basis. The mammogram should start at age 30, again on a yearly basis. So at age 30, what we recommend is the mammograms as well as the breast MRIs. And then we have some surgical preventive options as well. So that includes the mastectomy, which we know reduces the risk of breast cancer by 90% or more. With the bilateral salpingo-furectomy, that looks like it reduces the risk by about 90% for developing the breast cancer, but it also reduces the risk of ovarian cancer by about 50% or so. Again, there has been some debate in the literature, and that again has come out over the last year. We're really not sure. It may not be 50%, that is the real magnitude of reduction. And that's something that is an active area of research. So, next question. What about salpingectomy? Salpingectomy is removal of the fallopian tubes only. Is it proven to reduce the risk of ovarian cancer? False. Very good. So when we are talking about salpingectomy, the reason this has come up is there is evidence to suggest that many ovarian cancers may begin in the fallopian tubes. And bilateral salpingectomy, meaning removal of the fallopian tubes only, has been suggested as an interim procedure to reduce ovarian cancer risk, because the advantage here is it preserves the ovarian function and prevents premature menopause, which in and of itself presents a lot of health risks. But the situation right now is we don't have data to prove that salpingectomy reduces ovarian cancer risks. So really the next steps are to gather evidence, preferably through a randomized controlled trial, and really it would be a comparison of single-step bilateral salpingo-oophorectomy versus doing a two-staged approach, where you do the salpingectomy first and then the completion salpingo-oophorectomy. So going through why inherited cancer risk is important to identify, really it spans the entire cancer prevention and control continuum, whether we're looking at prevention, early detection, treatment, as well as quality of life and survivorship. So let's go back to this family. If this family had a BRCA mutation identified 11 years ago, how could that have changed their lives? Now, with Irene, she may have chosen bilateral mastectomy for breast cancer treatment instead of the lumpectomy. Her cousin, we could have prevented the ovarian cancer. And then most importantly, prevention or early detection of Anna's breast cancer so that her daughters would grow up to know their mother. So again, when we are finding these individuals, it can really change the course of their lives. So when we're talking about the clinical implications of identifying inherited risk, I think of three primary categories to impact that. So the first is the immediate treatment implications. If we're seeing a patient in the situation of an active cancer diagnosis, there could be some refinement in their treatment, either surgical or medical. In terms of tailored cancer prevention options, it could prevent them from developing cancer in the future or detect it early. And then the third thing, risk communication. So when we think of inherited cancer risk, it's really not just about the individual. So you can really think of it as the ripple effect of cancer risk. Families are our unit of care, and prior data has suggested that when we find a mutation in an individual, it's only a few members of the family that are getting tested, and that is a missed opportunity for cancer prevention. So looking at inherited cancer in medical care, again, we have a lot of inherited cancer genes that we know about now. That tells us what type of cancer risks individuals may have, which also then informs the management. So to me, it's a continuum of you find the gene, you then know what cancers an individual is at risk for, which then informs the medical management. So let's use BRCA as an example. We know that the cancer risks are primarily breast cancer and ovarian cancer. And then our management is primarily focused on breast and ovarian cancers. Same thing with TP53, which is the gene involved in Li-Fraumeni syndrome. Again, breast cancer, brain cancer, sarcoma are the primary cancers, as well as some other cancers. And then cancer risk management, again, is focused on that. And then P10, as we've already talked about. There are many cancers, in addition to the ones I've listed here, breast cancer, renal cancer, thyroid cancer, as well as some others. And then our management, again, is informed by what the elevated cancer risks are. So let's go to another family. So the reason for referral was a 39-year-old with DCIS. She had BRCA testing at an outside center, and no mutation had been detected. So here is her family history. You can see on her mother's side, there's some breast cancer, sarcoma, bunch of some more breasts and a kidney. On father's side, there's some breast cancers, renal cancer, a GIST in the 40s. So important to think about no detected. Is this a true negative versus an uninformative? To me, this is an uninformative. So when you find a result that you were not expecting, that is an uninformative result, because this is a very strong personal and family history, yet no mutation was detected. So bottom line, negative result does not mean no risk. So following her negative result, the treatment was initiated with lumpectomy and radiation, and subsequently the radiation oncologist recognized the family history and referred her for a comprehensive genetic risk assessment due to this family history. So what gene do we think this family has? Very good. It is TP53. So we test, this individual is tested. She has a TP53 mutation. Subsequently, her daughter was tested, also has the same mutation. Her sister subsequently developed breast cancer. It was a DCIS as well at age 37. She was tested at point of care, so at the time of her cancer diagnosis, also has that same TP53 mutation. Because she has it, she decided to undergo the bilateral mastectomy and forego the radiation treatment. And then subsequently, her sister and her daughter were tested. They also have the mutation. We were able to determine it comes from dad's side of the family because mom was tested and she was negative. So screening, when we're talking about screening for TP53 positive families, we have the high-risk breast cancer risk management. Colonoscopies are also recommended. And then the total body MRI is also a consideration. So that has been what's been implemented for this family. Now, over the past year, there was a paper that came out that updated the Chomret criteria for raising the suspicion for TP53 mutations or Li-Fraumeni syndrome. And one of the items that was added was breast cancer before the age of 31. So that's a little different from what we had previously recommended in that panel. So our panel actually refined the guidelines. It had read breast cancer before 35 is an indication for TP53 testing. So that is now 31. Again, stay tuned because the data is emerging and this may undergo additional changes as more data comes out. So again, implications to treatment are really, really important to think about in this family. So this scenario really demonstrates the implications to treatment following initiation of radiation, which is what happened in the initial patient, versus prior to initiation of treatment with radiation, which was the second patient. And the reason that's important is, there are suggestions of an increased frequency of radiation-induced secondary malignancies in individuals with TP53 mutations. And this recent study that I mentioned with the revised Chomret criteria, well, what they did was it was a study of 400 patients with Li-Fraumeni syndrome, and among the subset where treatment records were available and who received radiation for their first malignancy, 1/3 developed secondary tumors in the radiation field. And the mean latency was about 10 years. So again, there have been a lot of studies that have suggested it, but I think this is the best data out there. I think there is more research that is needed to be done, but per NCCN, this has been in the guidelines for a while now, therapeutic radiation treatment for cancer should be avoided when possible. Now, here's another patient. She was referred based on a personal and family history of breast cancer. She is a 43-year-old female with a recent diagnosis of DCIS, and she has a history of thyroid nodules, lipomas, and fibrocystic breast disease. And her motivation for testing was to make a surgical decision and inform risks for future cancers. So which gene do we think she has a mutation in? Excellent. So yes, it is a P10 mutation. So the P10 criteria were revised in the last couple of years based on some additional literature that had come out. Again, there was insufficient evidence for some of the common things that we find in family histories, like the benign breast disease, the uterine fibroids, GU malformations, and then there was evidence to include additional findings. So again, those are outlined in the NCCN guidelines. And then looking at the management recommendations, just to summarize it, we know that high-risk breast screening / surgery is something that is in the guidelines for individuals with Cowden syndrome. And then there are some other cancer risk management options that are also included. And what I wanted to focus on here was colonoscopy and renal ultrasound. So in this woman, after we found the P10 mutation, we did the colonoscopy, and what was found was multiple hyperplastic polyps. Renal ultrasound identified early-stage kidney cancer. So again, another scenario where when we find it, we can really make a difference in terms of the health of an individual. So what I've shown you is with breast cancer, BRCA1 and BRCA2 do account for the majority, but there are a number of other genes that account for a smaller proportion. And then there are neurogenes like ATM and CHEK2, where the risk level may not be as high, but there's definitely an association with the breast cancer. And the reason this has become more important is with these, we're able to test more because of the next generation sequencing technologies. So we're getting more patients that are positive for these genes. And the risks really vary between many of these genes. So to put things into perspective, DNA was only discovered, the structure of the DNA, in 1953. And by 2003, we had a full copy sequenced of the human genome through the Human Genome Project. And what's happened since 2003 is that the costs have really plummeted. So that is what is driving a lot of these the availability of next-generation sequencing tests. So in 2003, to sequence one human genome, it cost $2 to $3 billion, and it took about 5 years to complete. Right now, you can get it for about $1,000, and it takes a few weeks to complete. So the cost has absolutely plummeted, so we are able to test more. One of the first studies to use next-generation sequencing to evaluate inherited predisposition to ovarian cancer was conducted by the University of Washington group. And what they did was they did next-generation sequencing for some of the inherited cancer genes on 360 women, and they found 24% with germline loss of function mutations. The majority, again, were BRCA1 and BRCA2. But there were a number of other genes that were implicated. So that kind of showed us the power of next-generation sequencing technology to evaluate inherited cancer risk. So to kind of put it into perspective, the paradigm for genetic testing has really changed for us over the last few years. So in the past, what we would do is we'd do test one. So maybe we'd do BRCA1 and BRCA2. Say that was negative. Then we'd go on to our next test if it was indicated based on the personal and or family history. And if that was negative, we'd go on to our next test. So you can see how each of these tests costs thousands of dollars. That can be cost prohibitive. So right now what we're doing is we can do multiple genes all at the same time. And you know, I've put in here test 1, 2, 3, but we're talking 10, 20, 30, 40 genes all at the same time, which is much cheaper, but we have to remember the results interpretation can be more complex. And to kind of illustrate that, when we're talking about increasing cancer risk, we have our general population risk, we have our moderate or medium risks, and that's really what we're, when we're talking about medium risk, we're really talking about familial cancer. So the ones where we're seeing the family history, but it's not the classic BRCA families. And then we have the high risks, where it's the classic autosomal dominant inheritance, so the inherited cancer risk. So when we are doing this kind of testing, it's really important on the front end to talk about variation in the cancer spectrum and the level of risk with patients, because there are certain genes that we are going to act upon where we have really good evidence to act. And there are other genes where it may give them more information about why we're seeing the cancers in the family, but it may not be at the level where we're going to act on it. And then the other important item is the more genes we test, the more variants we're going to detect. And again, important to remember, we're not going to act on variant or VUS results, but there's a very high chance of finding them. So very important to mention that to patients on the front end. So when I'm talking to patients, really, we're talking about what are the different types of test results that you can get, and what is going to be the impact on medical management. And at the end of the day, really, we're looking for a gene that is going to make a difference in terms of their health. We may find other things along the way, but again, keeping the focus on, well, what is important when you're doing the inherited cancer testing. So here's another family. The reason for referral was somatic genetic testing results, which showed a PALB2, or a couple of PALB2 changes. And here we see a patient who had breast cancer at age 63. She's currently 71. She had a chest wall recurrence treated with chemotherapy at age 70, and then at 71, another recurrence, which prompted the tumor testing. She was referred to us, and we did the germline testing. And she has a PALB2 mutation. So just going through PALB2, this is one of the newer genes where we've gotten more data on in the last year or two. So the personal and family history fits with carrying a PALB2 mutation. The PALB2 associated cancer risks vary somewhere between 33 and 58%. It is modified by family history. There is a paper that came out in the New England Journal of Medicine in August of 2014 that is the largest study to date on this topic. There is an increased risk of pancreatic cancer as well. We think it's less than 5%, but we don't have it well quantified at this point in time. Now, there was another paper that came out in the past year that was based on a Polish cohort. There is a founder mutation in Poland for PALB2, and it confirmed the substantially elevated risk of breast cancer, somewhere in the range of 24 to 40%, so similar to the New England Journal risk. The 5-year cumulative contralateral breast cancer risk was about 10%, compared to 3% in non-carriers. And then what's very concerning here is the survival at 10 years was 50% versus 72% in BRCA1 and 74.7% in non-carriers. So again, you have to kind of balance it. We know that with PALB2, the risks are lower than what we would see with BRCA1. But if a woman develops breast cancer and has a PALB2 mutation, the chances that it would be an aggressive breast cancer are higher. So again, when we're having the discussion with patients, that's important to share. And again, these results are preliminary. We need more research in order to clarify these findings. But over the last guidelines, we did initially, PALB2 was not in the discuss option for risk-reducing mastectomy, whereas now it is based on the recent data that has come out. So here's another family. The reason for referral was personal and family history of breast cancer. Patient is a 57-year-old woman diagnosed with premenopausal breast cancer, treated with bilateral mastectomy at an outside hospital. And you can see, pretty small family structure, but there is an aunt who had breast cancer at age 40 and a grandmother with breast cancer at age 75. She had a CHEK2 mutation. It's a truncating mutation, very important. Truncating means that the protein is shortened, versus missense is when there's a sequence change, but the length of the protein is not changed. And truncating mutations are the ones that are primarily associated with elevated risks. Now, there was a study that came out of the Polish group again, published in JCO from a few years back now. And what they found was family history was really important in modifying the risk. So in this patient, with her personal and family history, we're talking about the range of 34 to 44% risks of breast cancer. So again, important to take family history into account because we can refine the risks of breast cancer in these individuals with CHEK2 truncating mutations. And again, you can see in the NCCN guidelines, we do have CHEK2 in the recommend breast MRI category because we know that the risks are over 20% lifetime risk. That is the ACS guidelines for recommending the breast MRIs. So here's another family, 51-year-old female, newly diagnosed with left DCIS with a family history of cancer, and she was referred for surgical decision-making and evaluation of risks for family members. And her risk assessment was pretty low. It was less than 3%. But you see here, she's got the breast cancer, and then she's got some aunts with breast cancer. She's got a half-sister with breast cancer, and then her half-sister and half-brother have colon cancer. So what gene do we think she's got? Very good. It is ATM. So looking at ATM cancer risk, the absolute female cancer, breast cancer risk is around 27. That number has fluctuated a little bit, so that's the best we have at this point. There is an increased risk for pancreatic cancer. Again, in the big scheme of things, we're talking less than 5%, but there have been studies that have substantiated this. And then there are certain environmental risk factors, mainly smoking, that can increase the risk of breast cancer among ATM heterozygotes. It is very important to remember that the 27% risk for breast cancer refers to most of the ATM mutations, but there is a high-risk allele. It's a C7271T to G allele. That one raises the risk to 60%. And, again, in the literature, it says that this is a rare mutation. We have 2 in our practice. I don't know how rare it is, but this gives a risk of 60% for breast cancer to age 70, which is in the BRCA category. So this is one where recommendation for surgery may be appropriate. So again, most ATM, we're talking, not super high risk, but the high risk allele does exist. Important to remember that. Now, given the high risk of breast cancer, the high-risk breast cancer genes were negative. This patient had come to us for a surgical decision. She proceeded with lumpectomy and radiation, which is very appropriate. We recommended the annual breast MRIs per national practice guidelines. And then I wanted to spend a couple minutes just talking about implications for family planning, because with ATM mutations, when they're found in a homozygous state, meaning if someone is a carrier for an ATM mutation and their partner is a carrier, there's a 25% chance that they will have a child with ataxia telangiectasia. And that is a childhood onset condition that leads to inherited cancer predisposition as well as many other findings. The carrier frequency for ATM is about 1%, so that's nothing. Again, something to talk to patients about when we find individuals that are ATM heterozygotes. Now, the other thing I wanted to talk about is testing in relatives, because we're talking about a 27% lifetime risk for breast cancer if you're mutation positive. Now, with her full sister, without the breast cancer, our patient's full sister, her lifetime risk of breast cancer, just based on family history, is 29%. So is testing really going to make a difference for her, whether she has an ATM mutation or not? I would contend no. So that wasn't someone that we would strongly recommend testing for in order to refine cancer risks. In contrast, her maternal half-sister without breast cancer has a lifetime risk of 11.7%. She is someone where if she had a mutation, that would change management, meaning we would recommend high-risk screening. And then when we're looking at her maternal half-brother and half-sister, both of whom had colon cancer, I would say it makes more sense to consider multi-gene testing that covers hereditary colon cancers, because there you have two relatives with early onset colon cancer. So let's go on to our next family. 43-year-old patient, referred based on a personal history of early onset breast cancer. When we initially saw her, she was very, very anxious, but was also very interested in testing. But her insurance didn't initially cover it. Now, there are labs that have financial assistance plans. So when she had a gap in coverage, she got covered through one of these plans, and she had the multi-gene testing, inclusive of BRCA1 and 2, performed. So what do we think this patient has? Very good. I can tell you we were really surprised that she had a Lynch mutation. And again, this was something that surprised her, but we had talked on the front end about the potential for getting unexpected results. So again, very important to set up patients to know that when we're doing this wider scope of testing, there could be unexpected results that they could receive from this testing. So shifting gears a little bit, looking at inherited ovarian cancer genes, BRCA1 and BRCA2 account for the majority. We're talking about 15%. But there's another set of genes that account for about another 10%. And those are the Lynch genes that have been known for a while now. But there are some newer genes that we included on the panel because of the evolving literature that really came out over the past year. And the ones I was going to talk about are BRIP1, RAD51C, RAD51D. So when we're looking at RAD51C, the ovarian cancer risks are 5 to 6-fold based on the data that we have in hand. And the lifetime risks are about 9% to age 80. When we're looking at RAD51D, the ovarian cancer risks are 6 to 12-fold. Again, that's a big range, but that's what we have right now. And the lifetime risks are about 10% to age 80. And then BRIP1, 3 to 9-fold risks. Lifetime risk, almost 6% to age 80. So again, this was the literature that was reviewed in order to decide that, hey, we have very similar risks to what we see in individuals with Lynch syndrome, so it's appropriate to consider risk-reducing oophorectomy, salpingo oophorectomy in these individuals. So here's another family, a 53-year-old female with breast cancer at age 45, treated with bilateral mastectomy, at which time she had P10 testing, which was negative, and BRCA testing had not been done. So what happened from there was at follow-up, she had planned a hysterectomy, but her gynecologic oncologist wanted BRCA results because he wasn't sure whether to take out her ovaries or not, and he didn't want to do that without knowing what her BRCA status was. So what do we think she's got? So yes, it's RAD51C. Again, we couldn't have called this one. When we found this result, again, the RAD51C is really not explained by this personal or family history. But really, what this clarifies is there are medical management implications. With the higher risk for ovarian cancer, it is reasonable to consider the risk-reducing oophorectomy. Predictive testing for family members is a consideration because, again, we're not seeing a super strong family history here, so the genetic test results could make a difference to their medical management. And then family planning is another important consideration here, because this RAD51C gene is also one of the genes for Fanconi anemia. So similar to ataxia telangiectasia, Fanconi anemia is an autosomal recessive condition. So if both partners have the mutation, there's a 25% chance that you could have a child with Fanconi anemia, which is a childhood onset cancer predisposing condition where there's a very high risk for multiple malformations and early death. So again, important to consider the cancer risk, but also important for family planning decisions in some people. So here's another family. A 31-year-old female referred with a recent diagnosis of unilateral retinal hemangioblastoma. And really what she had done when she came to us was researched von Hippel-Lindau disease in depth, and she was very, very concerned about her 2-year-old son, because von Hippel-Lindau is a condition that can manifest in childhood, and it is a cancer predisposing condition. So which gene does she have a mutation in? Yes, it is BRIP1. So we did find a BRIP1 mutation here. We also found a couple of VUSs, which aren't uncommon when we're doing this kind of testing. So this case, again, has implications to her medical management, because BRIP1, based on the current data, there are increased risks for ovarian cancer in terms of predictive testing. Again, in this pedigree, there aren't any other women in the family where it would impact their medical management at the current time. But then the family planning issue, again, is important, because BRIP1 is another one of the genes for Fanconi anemia. So important to mention that to patients when we are finding these mutations. So when we are doing genetic testing, again, things have changed a lot over the last few years because of the next generation sequencing technologies. And we have a lot of options in terms of what scope of testing to do. And from that standpoint, I think it's very important to discuss these things with the patient to figure out, well, what is it that they really want? Do you want to do BRCA testing first? Because with with breast cancer family history or ovarian cancer family history, BRCA 1 and 2 would still be at the top of my differential. So sometimes you can just do BRCA and then reflex to other genes. Another option is doing the smaller multi-gene tests, where you're doing it disease-focused, whether it's based on the breast cancer gene multi-gene test versus ovarian cancer multi-gene test. There are many multi-gene tests that are smaller, versus the pan-cancer multi-gene tests, where we're talking 20, 30, 40 or more genes. And again, some patients want to know as much as possible. Others really want to focus on what is important for them, what do we think we're going to find. So again, I think it's made things a lot more complicated for us, but it's also something that patients need to be comfortable with when we are advising them about the genetic testing. So with that, I wanted to thank you for your attention, and I think we do have a few minutes for questions.